Yeah. Thank you very much for giving me this opportunity. I am Dr. Hanjaban Banu Sharma. Let's begin the talk. Sports and exercise medicine is an subspecialty of the clinical interventional physiology, whose ultimate aim is CITES, Altius, Fortius, that is faster, higher, and stronger, with an ultimate, goal for achieving dop-free performance optimization with minimization of the injury and illness. And that's why sports and exercise training is very important. It forms the basis of sports medicine. Also, the basis of exercise, medicine, in the core of the exercise medicine, exercise prescription is there, where the ultimate aim is the use of the physical activity and exercise for health promotion and fitness, but also for therapeutic use for illness and injury. That's why the sports training and exercise training as a form of the physiological intervention, one has to be very, very careful, and it has to be precise, because overtraining can lead to different injury and illness, whereas undertraining can causes different problem, like for example subperformance. That's why monitoring has to be done, and the designing has to be very smart, specific, and the monitoring by using, say, physiological parameter like HRV or T by C, testosterone by cortisol ratio, because ultimately we want this upper reaching phase where optimum physiological adaptation or super compensation happens. Otherwise, overtraining syndrome can happen, or if the excessive training is accompanied with a lower energy intake, then relative energy deficiency in sports can occur, which is the topic of today. But one has to understand that this external internal load can be directed to injury or pathology, or into physiological positive adaptation by different moderator, because ultimately we have to achieve the performance enhancement, free performance enhancement with the injury and illness free. For that, you have to understand the modifier or moderator, like for example physical fitness. The physical fitness is one of the modifier. Also nutritional, sports nutritional consideration one has to take, like for example internal and external pressure for optimum performance can indirectly or directly affect the balance between the energy intake and the energy because of expenditure during the exercise. That is EEE, exercise energy expenditure. And because of this mismatch, low energy availability can occur, because sports are associated with the, say, extremely high volume of the EEE. Like for example, more than 30-hour training per week in some endurance sports can happen, or an attempt to improve the power to weight ratio, or desire to have an excessive leanness, or sports specific physic alteration, like for example gymnast, a dancer, or a distance runner. All these are has a very high risk for low energy, the availability, LEA. And this LEA can be of short term, that is known as adaptive LEA, which is benign, and which basically tells you about the flexibility of your physiological system, because your physiology try to compensate that. That is it indicates the physiological plasticity, where not much health detrimental effect is there. In fact, in some of the case, this relatively low energy availability can be done for a short time, and it may be associated with actually for a purpose to enhance performance also. But however, if it is done for a very long time and excessively done, then problematic LEA can happen, which is associated with substantial and potentially long-term impairment of both health and performance. And this ultimately will lead to what is known as relative energy deficiency in sports, that is negative both health and performance. So REDS is nothing but the syndrome of the impaired physiological and or psychological functioning experienced by both male and female, not only female but male also, because of the problematic that is prolonged or severe low energy availability, and which may be associated with lots of abnormality, which may be say decrease in energy metabolism, reproductive function abnormality, muscular skeletal problem, health problem, immunity problem, glycogen synthesis, or cardiovascular or hematological problem, which collectively or individually may lead to, say, impaired well-being, in increased injury risk, and decreased sports performance. This one has to understand. For that, you have to understand the energy availability. Energy availability is basically calculated by this formula, that is energy intake minus exercise energy expenditure divided by lean body mass. This is the and for for mass gain and growth, it has to be equal to more than 45 calorie per kg fat free mass divided by per day. And if it is around 45, that it means your weight maintenance is there. It is needed to support your body function. But it is I should say 30 to 40 45 kilocalorie, then it is basically a low energy availability, which is associated with the, say, body fat or body mass loss. But if it is less than 30 for a prolonged time, then it is problematic. That is the low energy availability, which causes health implication, health impairment. But the problem is this this cutoff, there is 30 cutoff, it is debated because no universally accepted clinically threshold for LEA is there, and this 30 is approximately equal to or equivalent to average RMR, and this 30 does not predict amenorrhea in all the women. That's why a particular cutoff value, using a particular cutoff value is problematic because we don't have, but it may be used as a sign of indication in case of the female, and this data was basically calculated with a sedentary female population. That's why for athlete, free going the athlete, so this using this data may be problem, but this can use as a guide. For male, the male has a capacity to resist abnormal body functioning to a relatively lower LEA threshold that is lower than the female, and that threshold can be 9 to 25 kilocalorie per kg free fat mass divided by day or per day. That's why, since energy availability, there is low energy availability, problematic low energy availability is the causative factor for REDH. That's why energy assessment, availability assessment, could be a diagnostic tool for prevention as well as management. But the only problem is, for assessment, you have to accurately predict the energy intake, you have to accurately predict exercise energy expenditure, you have to accurately measure the body composition by using DEXA or something like that, because you require fat-free mass in the equation. So that's why the practically measuring EA may be a problem, and because of that, there are so many indicator has been developed which may be used to predict whether screening of the REDS or actual diagnosis of the REDS, which may be used for monitoring as well as treatment purpose. And this REDS, it was started as a female athlete triad because it was it was found to be observed only in female in those days. And this female athlete triad is basically consists of the three components. That is, one is the low energy availability, that is less percentage body fat with or without eating disorder, and another is menstrual abnormality in the form of the functional hypothalamic amenorrhea because of the hormonal abnormality, because of this low energy availability. And because of this hormonal abnormality and the low energy availability, then osteoporosis can happen. So osteoporosis, or say stress fracture, all this thing, bone stress injury, all this thing. So these three triad, they form what is known as female athlete triad. But the point one has to understand then, that the female athlete triad is basically a spectrum. That is, the female can be the female athlete can have this extreme end of the spectrum, or everything in between. That is optimum energy availability, eumenorrhea, and optimum bone health. So everything in between, a female athlete can have. So this is basically a spectrum. And since it also affects other body system, REDS, that is relative energy deficiency in sports, was introduced by IOC in 2014. And you can see that the relative estimated prevalence can be as high as 23 to 79.5% in females, but in males also 15 to 70% in males also it can be there. That's why female athlete tried, the term has been abandoned. Now REDS term should be used. So basically, this the REDS, it affects lots of other body system, not only menstrual and bone health, but lots of other system, which may be immunological, GIT, cardiovascular, psychological, may lead to REDS, or REDS may lead to psychological growth, hematological, metabolic and endocrine, all these things. And this low energy availability, they also exist as a spectrum. Like, for example, adaptive LEA, where abnormality is not present, like this white line. But if it is problematic, then it may be associated with lots of abnormality, like, for example, reduced immunity, impaired reproductive function, or impaired bone health, impaired GIT function, impaired energy metabolism or regulation, impaired blood profile, that is hematological problem, urinary incontinence, impaired glucose and lipid metabolism, mental health issue, which may per se can also lead to a low energy availability, impaired neurocognitive function, sleep disturbance, cardiovascular abnormality, skeletal muscle function problem. So all these things can happen, like, for example, impaired growth and development. So this one has to understand. And there are lots of physiological, pathophysiological consideration, like just giving an example, because of this low percentage body fat, critically lower, less than the critical percentage body fat or low energy availability, the normal secretion, the pulsatile secretion of the gonadotropin releasing hormone from the hypothalamus can be affected, which may ultimately lead to the abnormality in the say pituitary secretion of the luteinizing hormone and follicle stimulating hormone, which will ultimately lead to the preproduction of estrogen and progesterone, and this may be associated with the say primary associated with the functional hypothalamic amenorrhea. And because of this abnormality of the estrogen, then bone health impairment can happen. Similarly, in the males, or also like testosterone secretion may be affected. Because of that, bone health may be problematic, and also low energy availability itself can causes bone health abnormalities. So all these things are the the basic pathophysiological consideration, and based upon the different laboratory testing, clinical testing can be used. Just give you an example, like for example, impaired reproductive function, overnight sampling of the luteinizing hormone, follicular stimulating hormone can be done. For menstruating female, phase-based hormonal approach, like using a urinary ovulatory kit can be used, or blood sampling can be done. For males, post-pubertal, morning total and free testosterone level can be used, or different questionnaire, like for example, lower energy availability in female questionnaire can be used. For male, lower energy availability in males questionnaire, or androgen deficiency in the aging male questionnaire can be used. For bone health, preferably DEXA has to be used. DEXA, and the interpretation has to be say age appropriate, sex appropriate, activity appropriate. And site also the use of DEXA has to be as appropriate, and medically appropriate body site scanning has to be done. Or you can record the bone stress injury or fracture history, or and sometimes you can also use high resolution peripheral quantitative computed tomography can be used. Like for example, an other system like impaired energy metabolism, you can use thyroid function test, or say leptin overnight sampling can be done, cortisol sampling can be done, or laboratory or expert or control measurement of different compartmentalized energy intake, the energy intake as well as expenditure in the form of say exercise or non-exercise activity, BMR or thermic effect of the food, or say cortisol or the RMR measurement can be done. For mental health, clinical interview with a psychiatric or psychologist is the gold standard, preferable. And whereas recommended, you can use different questionnaire, like for example, depression, you can use PHQ, that is the patient health questionnaire, or say stress perceived stress scale, or say profile of the mood state, or say eating disorder is very important, or disordered eating presence, you can use by different questionnaire, like for example EDQ, that is EDQ is the eating disorder examination questionnaire, or say BEDA, that is brief eating disorder in athlete questionnaire you can use, or eating disorder inventory or self report can be used. Similarly, also RAD affect the other performance parameter, and this may be different type of the injury, increase injury, say decrease endurance or muscle strength. All these things can be affected, both aerobic, anaerobic, as well as muscular health. And this low energy availability, if it is problematic, then decreased athlete availability may be there because of the injury or illness. It may be due to that decreased training response. The response to the training itself can be decreased, or decreased recovery may be there, decreased cognitive performance skill will be there, decreased motivation and psychological wellness will be decrease, and decrease muscle strength, decrease endurance in the anaerobic performance, decrease power output or power performance. Everything can be associated with the REDS. That's why not only health but performance is severely affected by the presence of the REDS, and that's why you can measure different say what do you call by using different laboratory technique. You can measure the presence of the different indicator for REDS. Like for example, decreased athlete the availability, it can be self-reported days of the training or competition loss, or modified because of the illness or injury. It can be reported by the patient, the player itself, or decreased training response to a we can track longitudinally by using any kind of the valid performance related specific metric specific to the athlete or the sports. Like for example, sports related time trial can be used, or say a different other technique can be used, like for the exercise lactate profile, or lactate is to say rating of perceived exertion ratio or catecholamine concentration, or decrease recovery. They can be used by, say, a lab-based like creatine phosphate system by using P31 magnetic resonance spectroscopy, or exercise induced muscle damage by using, say, muscle biopsy, or different questionnaire like, say, recovery stress questionnaire or POMS, or say creatine kinase measurement, or athlete subjective report of readiness, or say different wearable or commercially available recovery or readiness algorithm. The different gadgets are there. So this thing one has to understand. Not only this, the performance parameter is also important. The performance, the performance parameter using different physiological testing. Like, for example, decreased muscle strength. You can easily measure the decreased muscle strength by using, say, a different, by tracking longitudinally valid performance related metrics specific to that particular athlete or sports, which may be, say, for example, for weightlifting, snatch, or clean and jerk, or say a throw distance for the shot put, or say sports specific strength testing can be done, or you can use a isokinetic dynamometer. Isokinetic dynamometer can be used, or one repetition maximum, 1 RM specific movement, like, for example, bench press, you can use for a decrease in endurance performance. You can measure by, say, VO2 max assessment laboratory via indirect calorimetry. Assessment of the VO2 max. You can use a multiple multi-stage subtle run test, like, for example, beep test, yo-yo test. All these things you can use. The cycling RAM different protocol are there, or laboratory based lactate threshold measurement can be used, or ideally you have to use longitudinal tracking of the valid, any kind of the valid performance related metrics specific to that athlete or sports you can use. And for anaerobic or power related performance, wind gap test is the preferred one. Wind gap test, or if you don't have wind gap, then you can use RAST. There is running associated sprint test. There is movement also, like counter movement jump, or Bosco test, or standing broad jump. All these things you can use to track whether the performance, physiological performance decrement are there or not. This thing you have to understand. Like, for example, here in this case, you can see that in the swimmer, as compared to the as compared to normally cycling, there is normal menstrually normal player, the ovarian surface athlete, see, at the start, starting from 0 to 12 weeks, there is the swim 400-meter swim velocity significantly decreased. See, significant decrease is here. See, black line. See, this black one, there is close one, dark close one is the CYC. CYC is the normal, menstrually normal athlete, female athlete, and this white one, that is open one, is the ovarian surface suppressed, and you can see that how much their 400-meter velocity is decreased. See, decrement of the minus 9.8% decrement is there at the end of the, say, 12 weeks, or whereas the for, say, normally menstruating female, because of this training, 8.2% increment is there, in spite of the having same training distance. That is, in spite of the giving the same training, the performance, there is the responsiveness to the training and subsequent performance is reduced if the ovarian suppression is there, or if say female athlete triad is present, or if REDS is present. That's why performance is highly affected by the presence of the REDS. This one has to understand. And in order to understand, and in order to treat or in order to screen the REDS, you have to understand the clinical physiological model of the REDS. In this model, first you have to measure the different output of the REDS. That is by using different criterion, like, for example, health related output or performance related output. It has to be measured by different criterion, which are you have to identify specific impairment of the health or performance by which the body system might be disturbed by the LEA, that is low energy availability. And after that, you have to understand the characteristic of the LEA. It may be severity, it may be duration may be, say, short duration, mid or long duration. Short duration of the LEA, that is from days to weeks. That is mid is from week to months, and for long duration LEA is from months to year. This, and consistency, origin, everything, characteristic of the LEA, you have to understand exposure of the LEA, and the moderating factor, which modify basically which might alter the effect of the LE on the body system, whether to affect the health or performance outcome. These are the moderating factor. Like for example, gender is an important moderating factor, say as or gynecological as genetic factor or epigenetic factor. Like for example, different biochemical parameter, different anatomical parameter, medical history, like any kind of the medical disorder present, medication use, past medical history, or menstrual abnormality, or estrogen decrease or low testosterone in case of the female, PCOS or high androgen in females, or training history, like for example high impact exercise or low impact in the training, error resistant training, whether eccentric training or high frequency eccentric training is done or not, dietary consideration like energy intake, carbohydrate availability, like for example in a low carb athlete, or protein intake, whether it is sufficient or not, vitamin D status you have to understand. What about iron, this thing you have to understand, and the calcium, the energy density, intake of the caffeine and other stimulant, as well as other psychological factor, lifestyle factor, and environment, everything you have to understand. And after understanding everything, then you have to understand the mechanism behind the moderating factor and the health outcome. What is the relationship between that? So in this way you can this is the you can understand. That is the first, you have to see whether RADS outcome is present or not. Then you have to understand the LEA exposure, then the moderating factor, and then the interaction of the moderating factor with the outcome. This is the step number 4. This thing one has to understand. This is basically the clinical physiological model of the RADS. And after understanding that, then you have to understand the different risk stratification, as well as the for sports participation, as well as for treatment. Like for example, this traffic light signal system. For example, green means none or very low risk is present. There is no treatment, no need of the treatment. Then full training or competition is allowed. For yellow, then mild severity, mild risk is there. Treatment you have to do, monitoring you have to, and do follow up you have to do, but under supervision, full training and competition is allowed. For orange, moderate to high severity risk is there. Treatment has to be done, close monitoring is required, follow up especially monthly follow up is required. Some aspect of training and the competition has to be modified. And for a red means very high or extreme severity or risk is present. Immediate treatment with or without hospitalization is required. You have to follow a daily or monthly. Significant reduction or modification of training and competition has to be done. So these are the different way in which we can approach the clinically approach the RADS. This is basically a part of what is known as a clinical assessment tool version 2. And this is the same thing which I have mentioned already. Green, this is a yellow, and orange and red. But one thing which you have to understand is whether it is green, whether it is red, or whether it's yellow, there are different indicators. Like for example, clinical criterion, a maximum of one secondary indicator. There is no primary indicator. So you have to understand what are the indicator. Like for example, for yellow, in order to classify a particular athlete as a yellow, 1 or 2 primary indicator has to be present, plus minus maximum of 1 secondary indicator, or equal to or more than 2 secondary indicator has to be present. Like similarly for red means equal to or more than 4 primary indicator has to be present, or 3 primary with and equal to or more than 2 secondary indicator has to be present. So one has to understand what are the secondary indicator. But in spite of this color coding, if certain points, certain serious medical indicator are present, then immediate stoppage of the the training has to be done, and immediate medical attention has to be given, including potential hospitalization, removal from the training and competition. Like for example, if the median BMI, if it is less than 75% for age and sex, you have to be very, very careful. If it is electrolyte disturbance in the form of the hypokalemia, hyponatremia, hypophosphatemia, ECG abnormality, or say severe bradycardia, for example, adult, if it is less than 30 beats per minute, adolescents equal to less than 45, equal to less than 30, and hypotension equal to less than 90 by 45, or orthostatic intolerance, like for systolic blood pressure more than 20 millimeter mercury drop from supine to standing, or diastolic more than 10 millimeter mercury drop. All this thing you have to understand, and based upon this thing, in spite of that color code, you have to be very careful and check for all this time, so that immediate medical attention has to be given. So there are certain primary indicator which you have to understand, and you have to know these are the primary indicator. Like for example, primary amenorrhea is considered to be a severe primary indicator. They are counted as 2 primary indicator. For female, primary amenorrhea means what? There has when there has been a failure to menstruate by 15 years in the presence of a normal secondary sexual development, or say, or within 5 years after its development, if that occur after 10 years. This is basically the primary amenorrhea. amenorrhea, or a prolonged secondary amenorrhea. There is absence of 12 or more consecutive menstrual cycle because of the, say, functional hypothalamic amenorrhea, or for a male, it is a critically low free or total testosterone. These are considered as a severe primary, or the other primary are, say, secondary amenorrhea. For female, absence of 3 to 11 consecutive menstrual cycle caused by functional hypothalamic amenorrhea, or it may be, say, subclinical low total or free testosterone. There are lots of other factors, like, for example, say, subclinical or clinical low total or free T3, or history of the high risk equal to or more than one high risk BSI. That is the, bone stress injury, like, for example, femoral, neck, sacrum, or pelvis, or equal to more than two low risk BSI within previous 2 years. So all these things are considered to be a primary, and the presence of the primary, depending upon that, you have to color code this thing. For premenopausal females or male less than 50 years, then be a, bone mineral density jet score, you have to see. And, or say, the eating disorder, like, for example, EDEQ, depending upon that score, like equal more than 2.3 in females or more than 1.6 as in females, then you can consider it to be a, say, the primary indicator, or any kind of the clinically diagnosed based upon DSM-5 TR defined eating disorder. So all these things you have to check, and you have to consider them as a primary. And secondary are also there, like, for example, oligoamenorrhea caused by functional hypothalamic amenorrhea, that is equal to, or say, more than 35 days between period for a maximum of 8 period per week. You have to understand history of the one low risk BSI. You have to see within the previous 2 year, or absence of more than, say, less than 6 months from training due to BSI in the previous 2 year, or total or LDL cholesterol elevated. Well, LDL cholesterol is not much considered nowadays, but this is for historical purpose. You have to understand clinical diagnosed depression or anxiety. All this thing can be done. And apart from this secondary indicator, there are potential indicator also which are not counted in the diagnosis or the, say, stratification of the RADS, but which may has a potential important role. Like, for example, subclinical or clinical low IGF-1, critically low blood glucose, critically low blood insulin, chronically poor or sudden decline in iron study, lack of the ovulation, or increase resting or 24-hour urine, cortisol, urinary incontinence. All these things are very important. And also the psychological symptoms, like, for example, increased stress, anxiety, moods, body dissatisfaction, or body dysmorphia, because which may causes to eating disorder, exercise addiction, exercise dependence, excessive exercise. And because of that increased EEE, there is exercise associated exercise energy expenditure, low BMI, extreme bradycardia, or low systolic or diastolic blood pressure. So all this thing has a potential, can be used as a potential indicator. They are not classified as a secondary or primary indicator, but they are the potential, and one has to see whether presence or absence of potential indicator. And based upon that, what is the practical way? How practically we can approach? Practically, first you have to see the step one is screening by using a, say, questionnaire or something, where mass scale screening can be done. They are inexpensive. They can be used for a large patient. If some abnormality is present, like, for example, greater than low risk, then you have to do the step two. Step two is the high sensitive, more expensive tool, biomarker. Different biomarker, like I have already mentioned, for RATS can be the measure. And then based upon the step two, you have to classify yellow, orange, or red, and depending on that, you have to proceed to the stage three. Stage three is the clinical diagnosis and treatment, and this clinical diagnosis has to be sports medicine physician led. It has to be multidisciplinary, multi-speciality, team approach should be done, and proper diagnosis, and then based upon that, treatment has to be decided. So that's why this is a 3-step process of the practically approaching a case of the RADS. And one has to understand that a sports medicine or sports medicine physician or sports medicine specialist led final diagnosis is required, and that's why a presence of the sports and exercise medicine is very important. Not only sports and exercise medicine, but also a team of the specialty, multidisciplinary approach, like sports medicine physician, sport dietitian, sports and exercise physiologist, sports and exercise psychologist, psychiatrist. All this thing has to be present, and based upon different, say, questionnaire, interview, physical examination, physical assessment, laboratory and imaging data, data, and based upon that grading, red, green, orange, all this thing, then proper diagnosis has to be met, and after that proper treatment has to be done. Like for example, here in this case, in this study, we have we have used low energy availability in female questionnaire in 34 female athlete, and you can see that four are having the score of equal to more than 8 by out of 25, which is considered to be a high risk, potential risk factor for female athlete, right? And therefore these four are being has to be monitored, and can be subjected to a high yielding, high sensitive, high specific, different diagnostic investigation. And this LEFQ is based upon measuring three things. That is injury, what are the injury profile, what are the gastrointestinal function, whether some abnormalities present or not, whether menstrual abnormalities are present or not, use of contraceptive, all these things. Depending upon all these things, this questionnaire, this grading, this scoring is being done. These are the long distance runner and the dancer females, 18 to 30 years of age. And the treatment is ultimately, it is always and always team approach. One has to understand, and everything from red, orange, yellow, from yellow, orange, red, everything should receive medical evaluation and a treatment. And that the treating team has to be, a group of the professional sports medicine specialists, or an experienced doctor, dietitian, exercise physiologist, athlete training, or athletic therapies, sports psychologists, sports psychiatrists. One is very important. And also the athletic coaches as well as the guardian or parents should be aware of the diagnosis and the treatment. And the cornerstone of the treatment is to restore the athlete to have optimum energy availability. It can be done by two things. Number one is increasing energy attack and or decreasing energy expenditure. That is training, that is adequate appropriate training accompanied with a good sports nutritional input is very important. And RAD, education and behavior, RADS, it is S, education and behavior modification is the key. Athletes with RADS, they should be assessed regularly. It may be days or months depending upon the severity, and the key diagnostic fixture has to be tested again and again in order to confirm whether the normal body function are restored or not, and normal well-being are restored or not, so that proper continuous training can be done. And therefore, based upon this principle, primary prevention, the cornerstone is formed by education and awareness. Very important. Athlete as well as the, entourage, it may be coaches, health and performance team, parents, everything come under, this thing. And you have to, education is the key. Secondary prevention is the early identification using different type of the screening tool, which I have already focused. It may be health interview or objective assessment of the RADS biomarker. And tertiary preventer or treatment, the comprehensive team approach is very important. Sports medicine, nutrition, psychology, sports science person, as well as coaches and family member, everything has to be involved. And restoration of the optimum energy availability, where first physiological approach means you have to you have to brought in changes in a diet and exercise in order to achieve the sustain optimum EA, that is energy availability, with appropriate contribution of the macronutrient and the micronutrient, as well as certain pharmacological approach you can do. Like for example, 17 beta estradiol transdermal patches continuously can be used in accompanied with cyclic oral micronized progesterone in oligoamenorrheic endurance athlete. This has been shown to improve the bone mineral density chat score, or different psychological approaches there. But the point is, one has to understand that the treatment goal should ensure safe participation, sports participation, while undergoing long-term treatment and monitoring. Monitoring and treatment is very important, including risk stratification to assess the safety for continuous sports performance. And one has to understand that the approach should always be health first and performance second, because unfortunately among the athlete community, performance is always kept first, health is always kept second. But the approach has to be ideal approach has to be health first, performance approach performance second. This approach has to be used. So female athlete triad for a successful identification, treatment, of prevention of the female athlete, right? Integrated performance health management coaching model one has to use, where sports and exercise medicine, staff, personnel, and sports and exercise science, as well as coaching science, everything has to come together, along with the guardian and parent of the athlete and the athlete itself. And physiological approach first has to be used, because see, you have to understand, in order to improve the exercise availability, energy intake has to be improved, or modified exercise training has to be done in order to relatively decrease exercise energy expenditure, and improvement of the fat free mass is also important. So all this physiological approach first has to be done, with health first, performance second approach. And that's why positive physical activity, exercise, and lifestyle is the ultimate goal, so that we achieve the optimum physiological adaptation, so that health, fitness, and the performance optimization happens, and we avoid the syndrome like relative energy deficiency in sports, or overtraining syndrome. Thank you very much.